Hi. Hi. So we participated in the collaborative last year. So I thought I'd just talk a little bit about our approach to quality improvement, and maybe give people a little bit of advice, I guess, or sharing our experience with having a unique model and sort of having to adapt with quality improvement, because we are a nonprofit, and so we're not within the health authority. So we have, our own EMR and some limitations within that. So we kind of had to be creative and figure out our own process. So I first have to say that I don't have any conflict of interest that I know of. And so I'm just going to give an overview of our projects that we did last year and we're still doing, and share some of the challenges and successes. So for those of you who don't know, PHS Healthcare is a part of the Portland Hotel Society, and we operate in Vancouver and Victoria. And the PHS provides supported housing, low barrier supported housing, as well as a variety of other programs. We help run Insight, and we have social enterprises and have overdose prevention sites, a mobile needle exchange, and many other projects. So PHS Healthcare is a component of the PHS, and we operate, so we provide low barrier comprehensive primary care and mental health and addiction treatment in Vancouver and Victoria. And we're very low barrier. We see some of the most complex people in Vancouver in the downtown east side. And so how our model works is that we have clinical services within the Portland buildings, so 4 of the buildings. So we have a clinic on site in those buildings with nurses and a doctor. One of our sites has a social worker as well. And then we also operate a primary care clinic in the downtown east side, sort of a walk-in clinic, the Columbia Street Community Clinic. And we also run the Molson Clinic, which is our injectable opiate agonist therapy program. So injectable hydromorphone, as well as a injectable tablet program. So we give dilaudid tablets to people to inject. And so for Boost, we focused on Columbia Clinic. And at the clinic, we have usually 2 to 3 physicians with 2 to 3 nurses seeing up to 50 people a day. So our team was myself and our IOT nurse manager, Sarah Foster, as well as help from a few of our MOAs and physicians. And so we joined the collaborative mostly because I've never done quality improvement, and we wanted to learn. And we wanted to identify some of our gaps and improve our care, as well as connect with other teams and learn from what everyone else is doing. So we use the Oscar EMR. So a lot of the other groups, I don't know about the folks here, but in the Vancouver collaborative, a lot of the clinics use the same EMR, and there's forms embedded, the OUD form, the opiate use disorder form. We don't have one of those yet. We're working on it. And those forms are great for being able to just grab data, pull data really fast, pull reports. So Oscar is a little bit more cumbersome. So we weren't able to do that. So I had to adapt and find ways to measure and track people. And it was fairly time consuming, but we figured it out as we went. So I decided to focus on doing monthly chart reviews of our population of focus, and monitoring missed dose faxes and billing records, and then generally improving our clinic space and flow. So our population of focus, we decided to focus on 50 of the most frequent patients at the time. This was in the fall of 2017, who were on a subtherapeutic dose of OAT. And then as we went on, it expanded to increase to follow focus on people who were continually lost to care and missing their OAT doses frequently. So our aim statement at the beginning was 80% of our population of focus on an optimal therapeutic dose of OAT by June 2018. As we do pretty good job of getting people on OAT. We do same-day starts, we do rapid titrations, so that's never been an issue for us. But we realize that a lot of our folks don't get to a therapeutic dose, which is, pretty crucial. So we wanted to focus on that and figure out why is that and what can we do to improve that. So we started out by the first change we tested was to just ask people. So we picked our 50 people and flagged all their charts, and then every time they came into the clinic, we did a survey. So these are the questions we asked. I mean, these are questions that we asked anyway. I mean, most people, when you come and do an assessment of somebody who's wanting to, start out or restart out or increase their dose, you're asking these questions anyway. But we had the nurses just really focus on, what are the barriers? Why asking them, why are you still at 30 milligrams of methadose? It's been, months and months or years of just up and down, scripts getting canceled, or never making it past, 400 milligrams Acadian. And so we compiled all that info and asked them, what are the interventions? What do you think would work for you? What would help? So these were some of the answers that we got. So, things like, withdrawal and cravings, people just, they can't make it in to the clinic to increase their dose. They're not feeling well, so they buy street drugs. They can't get to their pharmacy. That's a big one. They just can't get into the clinic, or they have unstable housing. Their lives are chaotic. They just can't make it in. Or they feel judged. Some people don't like to just come to the neighborhood. Or they, I think the person who said everyone thinks I look like a junkie, I think he was feeling like, like he just didn't want anyone to really know about his use. So he was trying to avoid coming to the clinic, even though he lived in the neighborhood, but he still wanted privacy. Our clinic is too busy, which is a big one, we're a first come, first serve clinic, so we don't have appointments. So you just have to show up and hope and wait, and sometimes that's hard for people, and our space isn't very big. So also the medications are sedating, and they have side effects, and they don't want to increase. So some of the feedback around interventions were doing things like increasing clinic hours, reducing the wait times, being able to just pick up their script at the front desk, or helping with reminder calls, helping with withdrawal symptoms, rapid dose increases, more carries. People would like to have more carries and not have to come in all the time for new scripts, script renewal, pharmacy deliveries, and then help with stabilizing other aspects of their lives like housing. So from that, we use that feedback to try to implement some changes at the clinic. So we did start to increase reminder calls to people. The doctors did prescribe more deliveries for people from the pharmacy so that they could just get their medication in their home. We have social workers coming one afternoon a week, and that's been really helpful. Collaborative care planning with the overdose outreach team and downtown community court to care plan for some of the hardest to reach people, the people who are just have a hard time stabilizing on any OAT, and that's been great. We increased our OAT starting doses and rapidly titrating people. So we will start people at 40 milligrams of methadose, start people at a higher dose of Acadian if they have a history of opiate use disorder. And just changes generally to the space and making the waiting room a nicer place to hang out in and wait. And we have we hired peers. They're assisting us in the clinic with the flow, and that's been really great. They're really great at interacting with people and helping them out, and even just like running to the store to get someone a snack because they're they're getting agitated or things like that. that's really helped. And just improving our charting, and because how our clinic works is that the flow is that patients come in and they see a nurse first, usually, and the nurse does all the assessment, and then they go on to see the doctor. So just creating more efficiency with that, so that the doctor visit is more efficient. That allows us to see more people. And even simple things like reminding physicians to not end a script on a Friday or Monday. We were finding that was an issue because there's a lot of holiday Mondays, we're not open, or a script ends on a Friday and someone forgets, and then they have nothing for the rest of the weekend. And so we've been trying to improve that as well. So we still have things that we want to do with that, like research patient volume and schedule our doctors according to how busy we get on certain days of the week, and consider fast tracking, having a fast track where a doctor just does scripts and then other doctors do other things. Consider offering appointments. We might start to do that to some people, and do a follow-up survey. So that was So doing that survey was quite helpful, just to get an idea of where people are at and what some of the barriers are to increasing their out. And so as we were doing that, the numbers were showing, as I was tracking it and doing chart reviews and doing farm-minute reviews and seeing where people were at with their doses, I was seeing that people were they were reaching a therapeutic dose quite fast, and we do a really good job of rapidly titrating people. So that, as the months were going by, I realized that wasn't so much of an issue. What was an issue was the patients who were lost to care. I was starting to see through chart reviews how many people were just not coming back to us. They had been seeing us for months and then just dropped off the radar, and that was the most concerning for us. So we decided to focus on them, and so how do you do that? So, how do you track people that are lost to care, especially when we don't have an OUD form to just pull a report and see when the last time someone was in. So one tool we decided to use was the missed dose fax alerts from pharmacies, and probably a lot of your clinics get those. And we never really used them very much, besides the doctors using to renew scripts or whatever, but we decided to use those to try to see a pattern in people who were missing a lot. So we tracked those for a while. So if a person missed 2 doses in a row, we would try to, the MOAs would flag that, and then we would try to contact them. And it's tricky with our population. Some of them don't have housing at all, or their phone numbers change all the time. But we just got creative and tried to track them down, and collaborated with other teams to try to track people down, and we leave messages at pharmacies. And we also collaborated with a couple of the pharmacies that we have relationships with the most, and asked them to try to send consolidated reports, because doing it daily was so time consuming. So they started sending us a bi-weekly report, and then one pharmacy was sending us a report every month. So I would just go back and then do a review of the entire month and pick out the people who missed all the time. So that was helpful, but after doing this for several cycles, we just found it was just too time consuming to have staff dedicated to doing this. We just don't have the resources for it. And from what I could see from the data I was tracking, most people seem to come back eventually, like after several months. Most people kind of reappeared again. And so we decided that the input, the amount of energy just wasn't really working. So, but one thing that we did find, so the other change that we tested was through doing this work and through our MOA helping us, MOA Nicole, who was helping us, she does the billing for our team. So we're a fee-for-service model. So we have to do billing at the, monthly reconciling billing. So she would do the billing, and she was seeing, as she was going through her Oscar billing reports, she was identifying patterns in people that we haven't billed for in months. And so she found that that was actually quite easy for her to just pull those names. So we decided to try that, and we started doing that, and it was much easier, much more efficient than the misdosing reports. And so we did that, and we're still doing it. And so she just pulls names, and then she messages me, and I do a chart review, I do a pharmanet review, I'll find out if that person is anywhere else, and then if we can't find them, then we try to track them down and try to get them to come back. So that's been working pretty well. We've had people coming back to clinic from that outreach. So overall, so as one example, like in August 2018, we tracked 27 clients that were lost to care through the billing reports, and 6 came back within a month or 2 months. And then we continued to try to outreach the rest. So, I mean, to me, 6 is successful. If we can get 6 people who are completely gone coming back to the clinic, then that's great. So in terms of our aim statement, we didn't reach 80% of our population of focus reaching a therapeutic dose, but we got to 67%. So that's pretty good. Yeah, and we only tracked it until June. I haven't tracked it since, but. And then the other thing I wanted to share, and this isn't related necessarily to OAT, but another thing that we tracked, and that might be, and I think is a great project that we have that I just wanted to share with you, is that we have a peer accompaniment program. So a lot of our patient population finds it difficult to attend appointments, as I'm sure you've all experienced as well too. So we have peers that are dedicated to helping our patients get to their appointments and accompanying them. So we have an appointment coordinator that facilitates all the offsite appointments, to specialists, to ultrasounds, and she does reminder calls, and she also coordinates the peers and sets up pairs a peer with a patient if they really need help getting to an appointment. And so I wanted to track that because I wanted to know how successful that was, and people kept asking me, well, how successful is that program? So I tracked it for a couple of different cycles, and we found that it was overwhelmingly successful. So we had when people were accompanied by a peer, they attended 100% of the time, or 90% of the time. And when they didn't have a peer, it was very mixed. 36% of the time, 28% of the time. So that's pretty huge. So I'm using this data to try to get money. Basically, I'm to try to write some grants, and because obviously we know that how much it costs the healthcare system when people don't attend all those appointments and all those ultrasounds and the wait lists, and so yeah, I thought that was pretty interesting numbers. So yeah, I encourage, I don't know if it's, and we just do it through our fee-for-service model, like we just pay for, somehow we just find the money. Like we don't get any money for it, we just have a little budget and try to make it work. So yeah. So some of the lessons that we learned from being a part of the collaborative were that it's really hard to find time to prioritize quality improvement. It's, we're all super busy and just doing the work day to day, and but it was good to step back a little bit and just see the ways that we can improve, and it doesn't have to be a big thing. Like right now we're continuing on with the billing, tracking the billing, the names from the billing lists, and I'm not necessarily tracking the results, but we're still doing the work. And just, finding the challenge too was finding the most efficient process. And it took a while, it took several months to see what would work the best for us within the resources we have, but, eventually we found a system that worked well. And then finding efficient ways to measure it too, because we just don't have that forum yet to pull the data. So our successes, the data shows that our team does a good job in supporting clients that struggle the most. We do a good job with rapidly titrating people. And we have seen a pattern of improvement amongst many of our clients of the population of focus. We had some people who got housing went to treatment. Yeah, and my biggest lesson is that you know, we can find ways to adapt even when we have limitations with the systems that we have. We can still find a way to improve and track our progress, and yeah, that's it. Any questions?